Hello, my name is Leslie Scout. I'm a professor of radiology and surgery at Yale University School of Medicine, where I am Vice Chair for Education and Associate Program Director in the Department of Radiology and Biomedical Imaging. And today we're going to talk about ultrasound evaluation of the anal sphincter. And I have no disclosures that are relevant to this particular presentation. And my objectives are to discuss first the technique and normal anatomy of the anal sphincter, and then I'm going to concentrate on talking about ultrasound evaluation of tears of the anal sphincter. At the end of the lecture, we'll briefly talk about the role of ultrasound in evaluating patients with peri-rectal or peri-anal abscesses and fistulae, and then at the very end briefly discuss the potential of ultrasound to stage patients with rectal cancer. So patients usually present to us for evaluation of the anal sphincter because of fecal incontinence. And fecal incontinence is approximately 6 to 8 times more common in women than in men, and it's estimated in the United States that somewhere between 1 and 15% of all women over the age of 64 years have some degree of fecal incontinence. And it is my opinion, and I hope to convince you today, that ultrasound should be considered the first-line imaging modality of choice to evaluate sphincter integrity. And what your goal really is when you do this is to differentiate a tear in the sphincter versus neurogenic causes of fecal incontinence, in which case the sphincter will be intact. It's also important to determine the extent of the tear and whether or not the sphincter is actually fragmented, because that will affect management. And occasionally you will see atrophy of the sphincter as a cause of fecal incontinence. Now, the vast majority of patients with fecal incontinence actually do have a tear of the anal sphincter. And by far and away, the most common cause of such tears is obstetrical trauma. So this is much more common in women who have had children. And tears are particularly common if there has been mechanical disruption of the sphincter during delivery because of a midline episiotomy, use of forceps, or a large baby. But occasionally, traction injury during birth can actually tear the nerves leading to rectal or sphincter incontinence, although the sphincter is anatomically intact. Other causes of direct injury to the sphincter would include trauma or anal rectal surgery. However, there are several things that will cause fecal incontinence in the presence of an intact sphincter, and these include diabetes, other neurogenic causes, certain medications, advancing age, and patients who are treated with radiation therapy. There are two basic components to the sphincter complex, the internal and the external anal sphincter. The internal anal sphincter is an involuntary smooth muscle, and this provides about 85% of resting anal tone. And it is derived as a condensation of the circular inner smooth muscle of the muscularis propria in the rectal wall. And it runs from the anal-rectal junction to approximately 1 centimeter above the anal verge. It tends to be thickest in the mid-portion. It's usually similar in thickness in men as in women, and it averages about 2 to 4 millimeters in maximal dimension, and the thickness of the internal anal sphincter tends to increase with age. The outer component of the sphincteric complex, namely the external sphincter, is comprised of smooth muscle. And this does not begin as far cephalad, at least anteriorly, as the internal anal sphincter. And in the cephalad portion, it is typically fused or very closely related to the puborectalis muscle posteriorly. It extends, however, lower than the internal anal sphincter to the opening of the anal orifice and at least 1 centimeter below the lower margin of the internal anal sphincter. And the diameter of the external anal sphincter tends to decrease with age. Here is a schematic anatomic drawing, and you can see the anal canal centrally. Outside it, you see this hypoechoic band, and this is in a coronal plane, and this is the internal sphincter. Outside of that, you will see a band which is more echogenic on ultrasound, which is the external sphincter. And in between, you sometimes see these wisps of longitudinal fibers, a longitudinal layer of muscle that's in the intersphincteric space. On a three-dimensional ultrasound, you can see that the internal sphincter is typically in the very, very hypoechoic, almost black. And again, in the coronal plane, you can see that it parallels the wall of the anal canal. And outside of that, more peripheral, will be the echogenic external sphincter. And as you can see, it extends further south, if you will, than the bottom of the internal sphincter. And here you can see a further depiction showing that the external sphincter extends a little bit more inferiorly than the internal anal sphincter. Now, we evaluate in our laboratory the sphincteric complex using transrectal ultrasound, and we do this with a rotating or Sphincter probe that's at least 7 to 10 megahertz in frequency. And we generally examine our patients in the left lateral decubitus position with the knees bent. And the probe, of course, is covered with a condom and is lubricated extensively. And it's sometimes helped to have a lubricant that has a little bit of lidocaine within it in case it's a little bit painful. Now, no patient preparation is required for doing this exam, but I always do precede the examination with a digital rectal exam in order to assess rectal tone. And I will ask the patient to squeeze around my finger so that I can determine if they can squeeze adequately circumferentially, or if in the presence of the most common rectal tear that's located anteriorly, often you can feel that they can squeeze and clench the rectum posteriorly, but there is no movement or clenching palpable anteriorly. I then insert the probe and I start superiorly to identify the striated rectal gut wall signature. And when I see this striated gut wall signature, I know I'm in the rectum and I'm up above the sphincter. I then pull out very slowly till I identify the puborectalis muscle, and after that I continue to slowly pull out the probe, imaging every few centimeters, making sure to image in the high portion, the mid portion, and the lower portion. And if I have any questions, I will repeat that, having the patient clench, because the clenching maneuver often helps define the margins of a sphincter tear. So, starting with the normal anatomy, you can see that we've put in the probe high up above the sphincter, and you can recognize the clear striations of the normal rectal wall, where you see these rings of echogenic material surrounded by a ring of hypoechoic material, another echogenic ring, a hypoechoic ring, and then an outer echogenic ring representing the perirectal fat. And when you identify this, you know you are in the rectum, you're up above the anal sphincteric complex, and this is a landmark I use to know that I've inserted the probe high enough, and then I slowly start to pull it out. The first thing that you will see as you pull out and you lose that striated appearance of the rectal wall will be the puborectalis muscle. And this is a U or horseshoe-shaped structure that's usually of intermediate to echogenicity to slightly echogenic. And you can see that it has, again, these parallel glands, and it really is a sling that you can see in this transverse plane that's just holding the rectum and anal canal in place. And this marks the superior portion of the internal sphincter, which you begin to see as this very hypoechoic ring around the probe. This is a picture of the normal anatomy of the anal sphincter, and you can see centrally, this is the probe here, surrounded by a fluid, and the echogenic material around that is the mucosa and submucosa. And then you see this hypoechoic 360-degree ring, sometimes very, very hypoechoic, almost anechoic. And this is the typical appearance of the internal anal sphincter. Outside of that, in the transverse plane, you're going to see a 360-degree ring in the mid to lower anal canal, which represents the external sphincter. And you can sometimes see these little parallel bands within it. And as I said, it should go 360 degrees around the internal anal sphincter. Between the two sphincters, you sometimes see these hypoechoic, wispy little rings. Rarely are these confluent 360 degrees. You just sort of see this in pieces. And these represent these longitudinal muscle fibers in the intersphincteric space. I would like to point out that there is some variability in the echogenicity of the external sphincter, and sometimes it can be a little bit more hypoechoic than this, but in general, it is substantially more echogenic than the internal sphincter. Now, we talk about the sphincter in relation to the face of the clock, with 12 o'clock being anteriorly, 6 o'clock by the coccyx being posteriorly, 3 o'clock the patient's left, and 9 o'clock is the patient's right. And so once again, you can see here the probe centrally, surrounded by the echogenic mucosa and submucosa, the very hypoechoic 360 degrees intact normal internal sphincter, and then the more echogenic surrounding external sphincter in, again, a normal patient. So just to review the landmarks that I use, I know I'm in the upper portion if I'm just inferior to that horseshoe-shaped echogenic sling of the puborectalis muscle. And remember that when you're in the upper portion of the anal canal, you will not identify the external anal sphincter anteriorly. In the mid portion, this is where the internal anal sphincter is going to be thickest, and you are going to see a complete external anal sphincter ring in the normal patient. And lower down in the anal canal, the internal anal sphincter will not be present, but remember that the external anal sphincter will extend at least a centimeter caudal to the end of the internal anal sphincter in the normal patient. And tears are very easily detected on ultrasound as discontinuity of the structures that I've just described. So here is a patient that has a very large tear anteriorly of both the internal and the anal sphincter. And we would describe this again in terms of the face of the clock, and you can see this big hypoechoic tear disrupting the echogenic echotexture of the external sphincter, and it extends approximately from 11 o'clock to the 3 o'clock position. Underneath, you can see the internal sphincter, and you can see that it's attenuated from about 1 o'clock to 3 o'clock, but is clearly disrupted from about 1 o'clock to the 11 or 11:30 o'clock position. Here's another example of a patient with a large anterior tear, which again extends from approximately 11 o'clock to 3 o'clock, and here on another image, 11 o'clock to 3 o'clock in the external sphincter, and here the internal sphincter, it extends from 12 o'clock to 3 o'clock, where you see complete disruption of the hypoechoic ring of the internal sphincter anteriorly and towards the patient's left. And again, on this image, the tear in the internal sphincter is from 12 o'clock here to approximately 3 o'clock here. Here's another example. Now I can tell I'm up relatively high here because I can identify posteriorly that U-shaped sling of the striated intermediate echogenicity of the puborectalis muscle. And notice that the external sphincter is going to be closely opposed to that posteriorly. But remember, in this location, you can't really normally see the external sphincter anteriorly. So I won't say that there's an external sphincter tear on this image, but notice that there is a very large tear in the internal sphincter anteriorly between approximately the 10 o'clock and the 3 o'clock position. Sometimes having the patient clench can make things a little bit more visible, and we've pulled down a little bit, so now I can clearly see the external sphincter. And here, once again, I can see that tear in the internal sphincter from about 10 o'clock to the 3 o'clock position, and notice that I can now identify this hypoechoic tear disrupting the normal right echogenicity of the external sphincter from 12 o'clock to the 3 o'clock position. Very often, as I have just shown you, the tears are what I would call congruent, and they're in the same location and they're roughly the same size when you can compare the tear in the external and the internal sphincter, but this is not always so. And again, it is very important to make sure that the referring clinician knows whether or not the tears are in the same location and if there's the same size. So here in this patient, you can see that there's a big tear in the external sphincter from approximately the 9 o'clock to the 3 o'clock position, but there's only a very small anterior tear in the internal sphincter, as you see here, from approximately the 12 o'clock to the 1 o'clock position. And here's another example. Actually, these are two different patients where, again, anteriorly you see this very large hypoechoic tear here in the patient on the left from approximately 10 o'clock to 3 o'clock, and in the patient on the right from 9 o'clock to 3 o'clock in the external sphincter anteriorly. But you have a very small tear from 12 to 1 in the patient on the left in the internal sphincter anteriorly, and from maybe 11 o'clock to 1 o'clock anteriorly in the internal sphincter. You see this echogenic tear disrupting the hypoechoic rim of the ring of the internal sphincter in the patient on the right. So again, some discordance in the size, although both of the tears are anterior. And here is a different situation, which again, very important to identify for the referring clinician. This patient clearly has a large tear in the external sphincter, and it goes from approximately 10 o'clock to the 2 o'clock position. You can see this big hypoechoic heterogeneous tear disrupting the echogenicity of the external sphincter. But notice that the internal sphincter, this very, very hypoechoic ring, is completely intact. So here you have a tear of the external sphincter, but an intact internal anal sphincter. And here's another example where, again, the hypoechoic ring of the internal sphincter is completely intact, but there is a large hypoechoic tear anteriorly from approximately 10 o'clock to 2 o'clock in the external anal sphincter. And yet one more case showing a more intermediate echogenicity tear from about 11 to 1 o'clock in the external sphincter in the setting of an intact hypoechoic ring of the internal anal sphincter. And this is kind of an unusual case because this is a very small tear in the external sphincter. Again, note that the inner hypoechoic ring of the internal anal sphincter is completely intact, but there's a very tiny hypoechoic tear in the external sphincter from about the 2 o'clock to the 3 o'clock position. And this is somewhat unusual just because the tear is so small. Now, in this particular patient, what you can see here on the left is that both sphincters are intact, but notice that there is variability in the width of the internal sphincter, and it is quite attenuated and thinned between the 12 o'clock and the 3 o'clock position. The patient on the right has a tear in the external sphincter anteriorly, as you see here, relatively heterogeneous hypoechoic disruption of the external sphincter. The internal sphincter is intact, but notice again it is very thinned in kind of an unusual location from about the 3 o'clock to the 6 o'clock position. And in addition, there seems to be compensatory hypertrophy of the rest of the internal anal sphincter, which is thicker than what you normally see. This patient has a tear anteriorly, a large tear from about the 9 o'clock to the 3 o'clock position of both the internal and the external sphincter. And notice that the external sphincter is very attenuated as well. So again, it's important to pay some attention to the width of the sphincters, how well you see them, because in this case, surgery may not be all that helpful because you can fix the tear, but you're not going to be able to do much about the diffuse attenuation of the external anal sphincter. And here is another patient that has somewhat complex problems, and you can see an anterior in this patient on the left. You can see a tear anteriorly from about 10 to 2 o'clock in the external sphincter. You can see that there's probably a tear from about 9 o'clock to 2 o'clock in the internal sphincter, though perhaps there is a strand or two of the internal sphincter present, but it's at least extremely attenuated in that region, but there's clearly marked hypertrophy of the internal sphincter posteriorly. And here you can see similar findings in another patient with marked posterior hypertrophy of the internal sphincter, where it measures nearly 6 millimeters in diameter, as I mentioned, 4 millimeters is usually the upper limits, and again, a large tear here of the external sphincter anteriorly, and marked either attenuation and thinning of the internal sphincter anteriorly, which I believe is still intact, but really they're just a very few fibers that are intact in the internal sphincter anteriorly. Well, moving on to discussing peri-anal abscess and fistula. In most patients, these are due to obstruction of the intersphincteric glands, usually secondary to fecal impaction. But you can also develop peri-anal abscess and fistula in the setting of inflammatory bowel disease, particularly patients with Crohn's disease, or patients who have other types of infection, and sometimes following trauma, again, including rectal or anal surgery. And basically, what the surgeon wants to know here is the location of the fluid collections, their size, and whether or not there are sinus tracts. And if there are sinus tracts or fistula, they need to know the relationship of these to the sphincter, the number, and the complexity. And this is very, very important because when they go in to drain or resect these abscesses or fistulas or sinus tracts, it is missing a sinus tract that is the most common cause of recurrence of this type of pathology. So here is an example of a kind of lobulated, very large perirectal fluid collection that is a peri-anal abscess. And again, it's important to let them know how deep it goes, and if you can't see how deep it goes with ultrasound, further imaging with MR or possibly CT would be indicated. We always look with color Doppler, and it's a little bit surprising that we didn't see any increased vascularity in the peri-abscess soft tissues, but of course you would not expect to see any vascularity within this conglomerate appearing abscess. If you did, you'd be concerned more that you had an abscess or a phlegmon or an underlying mass rather than a straightforward abscess. These are some examples from the literature demonstrating in both cases very large horseshoe or U-shaped abscess posterior to the anus and posterior to the sphincteric complex, which, although immediately juxtaposed to the abscess, is not affected by it. The patient on the left has a relatively homogeneous fluid collection of intermediate echogenicity. On the right, the collection is a little bit more complex, and these little echogenic areas, of course, represent air within it. Now, this air could be from gas-forming organisms, but when you see air within the abscess, it should make you question whether or not there's fistulous connection either to the outside or to the vagina or to the rectum. Sometimes you can identify air within a fistulous tract looking through the vagina, aiming your probe posteriorly, and that was what was done here. And here you can see the hypoechoic internal anal sphincter. The more central echogenic bit here is the rectal mucosa, and here anteriorly you see this focal echogenic area that's got some dirty shadowing here, and this represents air that's disrupting the internal anal sphincter anteriorly at the 12 o'clock position, and this was due to a vaginal anal fistula. Here is another example of a patient with a vagino-rectal fistula, and you can see this linear echogenic line on the transrectal ultrasound extending anteriorly from the vagina through the external sphincter right up to the internal sphincter, although it doesn't involve the internal sphincter. But you will see some additional pathology, namely from about the 10 o'clock to the 12 o'clock position, that there is a disruption of the internal sphincter. So there's a tear of the internal sphincter in addition to this fistulous tract between the vagina and the rectum or the anus. And for those of you with really sharp eyes, you'll see where the orange arrows are that there is a second and perhaps a third echogenic linear tract through the external sphincter to the level of the internal sphincter at about the 10 o'clock position. So this is a complex constellation of findings. It's important that the surgeon know that there is an accompanying tear of the internal sphincter so that that can be fixed at the same time that the fistulous tracts are resected, and that this isn't just a simple fistula through the external sphincter at the 1 o'clock position, but there's a second and possibly a third smaller tract at about the 10 o'clock position. And this is very important because if one had missed these tracts over here at the 10 o'clock position, as I mentioned, this is a common cause for recurrence of symptoms and even recurrent abscess formation. And here is a final example where you can see this echogenic material. In this case, it is in the intersphincteric space and involves the internal sphincter, although the external sphincter does not appear to be so involved. Though again, we're up relatively high, you're beginning to see some of the puborectalis sling here. So again, this is an example of air disrupting the internal sphincter and the intersphincteric space at about the 10 o'clock position. Well, the last application of transrectal ultrasound that I wanted to discuss is its potential for staging patients with rectal cancer. And the beauty of transrectal ultrasound is that you can identify the different layers of the rectal wall, and this is the typical gut wall signature that you can see with ultrasound. And the layer that you really want to carefully identify is this outer hypoechoic band, which is the muscularis propria. And the reason for that is that if the tumor is contained by this band, is either, in other words, central, and doesn't extend beyond that, it is a T2 tumor, and a T2 tumor can be treated with primary surgery. If, however, the tumor extends through the hypoechoic muscularis propria into the surrounding echogenic adventitial layer or perirectal fat, it becomes a T3 tumor, and those tumors are optimally treated with primary chemotherapy and radiation therapy, and only subsequently have surgical resection. So here is an example of a very large rectal cancer. This is the probe here, and you can see all of this hypoechoic mass from about the 12 o'clock going to the right and posteriorly to the 3 o'clock position is all tumor. You can see a little bit of the rectal wall signature from anteriorly and to the left here from the 1 o'clock to the 3 o'clock position. And there you can clearly identify the outer hypoechoic rim of the muscularis propria. And you can see that that rim is intact, and the tumor, although very large, is contained within that. And this would be, although a very large tumor, would be, at least by ultrasound, a T2 tumor. Understanding that ultrasound is not very good at differentiating between microscopic invasion of the adventitia and little inflammatory changes. So really, we typically only call T3 tumors or invasion of the adventitia when you see things like this, where you actually clearly can see lobular extensions of the tumor clearly beyond the rim of the hypoechoic band of the muscularis propria. So in these two patients, this is one patient down below and a second patient anteriorly, you can clearly see this large tumor disrupting all layers of the rectal wall, clearly extending anteriorly into the echogenic perirectal fat. And here in this very large tumor, you can see several areas here at about 4 o'clock, here from 9 o'clock to 6 o'clock, where you see these lobular extensions of tumor into the perirectal fat and probably some adjacent lymph nodes as well. So again, a T3 tumor. So in conclusion, transrectal ultrasound is easy, it's safe, it's well tolerated, but it is operator dependent, and you need to know the anatomy in order to interpret your images. I think it ought to be the first-line imaging modality of choice for evaluation of anal sphincter anatomy, and it is extremely accurate in differentiating a true tear from neurogenic injury. And transrectal ultrasound, in our experience, has about 100% sensitivity and a little bit less lower positive predictive value for identifying these tears and determining whether or not the external or internal sphincter or both are involved. And again, if these sphincters are intact, the cause of the incontinence would be neurogenic injury. I do want to advise you to recognize, though, that sphincteric tears particularly in the setting of obstetrical trauma, do not very often occur in isolation, and often they are involved with multi-compartmental disease, with prolapse and urinary incontinence, and so sometimes MR or three-dimensional ultrasound of the pelvis can be helpful to evaluate for posterior or multi-compartmental disorders. We used to do endovaginal ultrasound in our practice and have seen in the literature that it's reported to have 100% sensitivity for at least internal anal sphinctal tears, but we have actually had several false positives, and we certainly do not think it is very helpful for evaluating tears of the external anal sphincter, so we no longer include endovaginal ultrasound for evaluation of the internal external sphincter in our practice. And as always, one of the exciting parts about ultrasound are some of the new technologies and advances, and in the future I think three-dimensional ultrasound of the pelvis and of the anal sphincter will provide us even more information to help our surgical colleagues. Thank you very much.